region, and we need attention to it. Friends, that is not only my opinion. You can ask to any surgeon who is working in this region. Of course, if the surgeon doesn't work in this region, he or she will tell you that this is not the problem. But if really this is the specialist who makes some performance in the neck region, they will honestly tell you that this is awfully hard region with huge amount of the possible surgical complications. And my first lecture about neck, I start from this. I don't need to repeat it once again. I think I prove you with very many specificities which I mentioned, yeah? Spaces, vessels, the specificity of the wound, specificity of the sensation. I think I prove you that this region is really surgically hard. That's it. Then you make surgical some performance. We have some rules. First of all, rule number one say that surgery in the neck, if it is possible, make maximally short or minimally short. I don't know how to say. Because prolongation of the surgeries in the neck region can make the possible complication. Second, any piercing, printing surgical instruments like the Kocher forceps, like I don't know, the surgical dissecting forceps, forbidden. Why? Because we are very small, very polite, invisible, and undetectable superficial beings. Why undetectable? So usually how we detected the presence of the vessel? By bleeding. Surgery cut the vessels so you see bleeding, but not the vessels with the negative pressure. And you cut the vessel with the negative pressure, sorry, you don't see any bleeding. That's an evidence of your cutting is not visible. And it can simply gives the formation of the air embolism about which we mentioned before. Usually what do you see in the movies, cartoons about surgery? Arterial forceps apply, and in the finish of surgery only it is ligated and removed, but not in the neck. More than 2 minutes, if it will be applied in the wall of the superficial vessel, it is enough to perforate it and to form the air. That's immediately apply arterial forceps, ligate and remove. The longer it will be ligated, the more will be the chance of formation of the complications. Remember about it. More of this. Some surgeons will tell you that primary in the neck arrest the venous movement and only after it heals. Again, due to possibility of elimination of the air embolism. Air embolism develops very fast and kills the patient very quick. Next rule in the neck region say that no any performance without serious anesthesia. Serious usually is general. You know, there are 3 forms of the anesthesia. It is the local, it is the regional, it is the general anesthesia. Here we use mainly in 99% of the cases general anesthesia. Why? Huge innervation. Second, traumas of the neck region or surgical performances can give the shock pain reactions. To avoid it, of course, we try to use very serious anesthesia. As I say, surgeries generally will divide into 4 groups: surgeries on the vessels, on the nerves, on the organs, and finally on the purulent processes. And I will start from surgery on the vessels. Huge arteries, 2 huge arteries, and huge amount of branches of these huge arteries we have in the neck region. Primary is common carotid artery, it's a subclavian artery with the branchings which we described before. Damage of each these artery can give the mortal bleeding and very, very fast. Example, if for common carotid artery will be damaged, less than 5 minutes is necessary to lose 50% of the blood and to have mortality. So you understand that the time is short, you must make extremely emergency manipulation to save the life. And I will explain now for you how we can do it, how we can make this performance. Second case that you make to open the vessels, it is to make some distance manipulation. For example, endoscopical manipulation in the vessels, or ligation in distance. If not immediately this artery is damaged, but the tributaries of this artery. And if it is impossible to work inside of the wound, I gave you several cases, I don't have time now to repeat. You know, there are several situations that work inside of the wound or impossible or very hard. And you prefer to work with magistral vessels, of course. Of course, guys. Then you work with magistral vessels, you will keep in your mind that this is serious situation. Magistral vessels, it is not so simple structures. They supply big regions, and sometimes after the ligation, they can give the huge necrosis up to mortality. For example, try to ligate internal carotid artery, and you will see what will be happening. 100% of mortality. I told you in the same time, no any problem, then you ligated one-sided external carotid. Majority of cases, no problem, then you ligated common carotid. You remember I drew for you in the lecture. Yeah, retrograde supply. But again, to be attentive to not apply your ligatures near the bifurcation. Otherwise, the clots of the blood can simply close them. Now, finally, how I can arrest the bleedings in neck region? Temporally or permanent? Permanent method, it is mainly ligation in distance. According to projections, place of location, I open the stent. What is temporal method? I tell you, or pressure. How we press the common carotid? I say, find please midpoint of posterior margin of your SCL. Push your fingers perpendicular to skin to inside. If you will push it into 2 centimeters approximately, common carotid will be pressed to the tubercarotid, which we draw before. And it puts temporary rest. Make the tourniquet in techniques. Not so good, but anyhow, protect it opposite side by something strong. Apply the tourniquet and push the press only one side. Time which you will have not so long, minutes. Because if after 1 hour you will close it, it will give the necrotization inside the crack. How we open common carotid artery and its branches? In 99% of cases, we open external carotid branch to ligate it in distance. For example, wounds of the face, frontoparietal occipital region. Yeah. If it is impossible to work immediately inside. Look to me. First of all, we palpated thyroid cartilage. We find upper margin. We provided imaginary line up to cross it with anterior margin of SC. From that point, your incision passed by anterior margin to upwards into 6-7 centimeters. Once again, cross point between upper margin of thyroid cartilage and anterior margin of SC. From crossing point along the anterior margin of SCM into 5-6 centimeters. Layers. You cut it skin, fat, superficial fascia, upwards, you don't have platysma generally. Then, using the groove probe, you cut the second fascia, you open the space, capsule of SCM muscle, because here we have the capsule. You put the hook in the muscle, you push it into the back, you cut the posterior wall, and immediately after this, in front of your incision, you see parietal layer of tissue, which is formed as spacyplasm abroad. By same groove probe, you cut it, and you find the place of bifurcation. I told you in my lecture that there are 3 methods how to recognize external one: position, pulsation, branching. Using these methods, you find it. Rules of ligation, you know better than me. 2 ligatures proximally, 1 distally. First loose, second, third strong. Distance between first, second, 0.5, second, third, 1. That's all. How we can open common carotid artery? Usually common carotid artery you open to clip the artery temporarily. For example, by Bulello forceps. For example, you make endoscopical some intervention. Thrombectomy. And you must temporarily close the artery. But also you can ligate it. I say critically hard conditions. 3 places for access. Carotid triangle, omotracheal triangle, lower third of SCM. In carotid triangle, same upper margin of thyroid, up to cross point with anterior vessel, but now from this cross point, incision descending down along anterior margin of SCM. So you open the place not above bifurcation, but below bifurcation. Omotracheal triangle, look to me, angle between upper belly of omohyoid and SCM. From angle 6 centimeters to down, again, along anterior margin of SCM. Do you understand me or no? Yes. Yes. Do you understand or not? Repeat please. How in omotracheal triangle I can open common carotid artery? You start great. By do you appreciate your knowledge? So, you're very hungry, for example. I give you something very tasty. Will you take and eat it or not? I give you now knowledge which is 100 times more important for your health than this food. Because whole your future will be based in this knowledge. Why you don't listen? Or I ask you, I say, friend, if you don't understand, sure I will repeat it for you. Why you say, no, sir, don't worry, I understand everything. What is the logic? Now look to me. In omotracheal triangle border from upwards by omohyoid muscle, downwards by SCM muscle, and from middle side, midline of the neck. Now, these two muscles which I mentioned forms the blend angle. Starting from this angle, you make incision along the anterior margin of SCM into 6 or 7 centimeters to down. Do you understand what it is? I'm not sure. Let's continue. Last place of access, it is inferior third of the SCM, strongly by midpoint of the length or of the width of SCM muscle, you make vertical incision. And you go between 2 heads of SCM muscle. One is to sternum, second to clavicle. You pass between these 2 heads, under of it, you go in retro sternocleidomastoid space, then exactly you see the parietal layer of fourth fish under the third fish here. Again, you open it, again you what? Understand? How we make access to subclavian artery? We do it in omoclavicular triangle. Anteriorly, it is posterior margin of SCM. Posteriorly, it is anterior margin of trapezius. 1 finger above the clavicle and parallel to it. Once again, 1 finger above the clavicle and parallelly to it. From posterior margin of SCM to the anterior margin of trapezius. Skin, fat, platysma first fissure, second fissure, you become to suprasternal space, you ligate it here anterior jugular veins, you cut third fissure, finally you cut fifth one, and finally under it you find subclavian artery. First portion, scalenovertebral triangle, second portion, interscaleneous space, third one, just a triangle above the clavicle, under the fifth fissure. By the way, where is your subclavian vein? Subclavian vein located in front of artery, in so-called antescaleneous space. Now look, space which is between clavicle and anterior scaleneous muscles. Where is your plexus brachialis? Plexus brachialis located above and behind of subclavian artery. By the way, in the neck we have the cords, in axillary region we have the in neck we have trunks, in axillary region we have cords, and final branches. Trunk is 3, superior, posterior, inferior. Cords is also 3, lateral, medial, and posterior, and final branches. Questions? You are so healthy persons. I have questions and you don't have completely any question. Read them. Goodbye or no? No, if you have another options, tell me. If no any other options, we can be goodbye.